So hello everyone. Now we are going to discuss regarding the management of acute and chronic constipation. So before going into that, obviously just recapitulate a little bit regarding the definition and the classification. So it's basically infrequent or difficult passage of stool, that is your constipation for you. So there is a room for a criteria that basically used, which basically states that less than three uh, bowel movement per week, and there is a straining. Also, there is a hard stool, sensation of incomplete evacuation that is needed to call a symptom or call it a constipation. Now we have two classification, it is the acute and the chronic. So your acute state, when the disease stayed there for less than 3 months duration, but if the symptom is there for more than 3 months, it's the chronic. Now let's try to understand what is the approach to the acute constipation. So here, first of all, what we need to do is that rule out obstruction. This is the first thing. So for to rule out the obstruction in case of acute constipation, we need to take the history of whether there is a vomiting, there is a nausea, there is a obstipation, right? And in the examination, you must check for the bowel sound is there or not, whether there is a, most of the time patient will show like distended abdomen, right? And the thing is that imaging, obviously you have your chest x-ray is there, straight x-ray abdomen, which will eventually gives you idea regarding whether it is small bowel or the large bowel obstruction. But also apart from that, your USG ultrasound is also there, and the cross sectional imaging like the CT is supposed to be done in case of stable patient. One thing that obviously I would like to highlight is that there is few red flag signs are there, like there is a sudden onset features, there is a weight loss and associated with the bleeding like hematemesis and melena. In certain cases you must rule out for the gastrointestinal cancer in that case, right? Also you need to learn regarding the initial management. So here during the acute constipation, we do like to go for enema or suppository if we are able to found impacted stool in digital rectal examination or the DRE, right? Also, you need to address if there is any underlying cause, like maybe it due to the some drug induced, or sometime maybe due to the dehydration. So you do need to address the cause and treat accordingly in that case. Okay. Now regarding the evaluation of the chronic constipation, exactly same detailed history and physical examination will always going to help you. Regarding the digital rectal examination, what I do um, need to inform you that, like regarding the digital rectal examination, you must check for the sphincter tone in this patient. Also look for if there is any associated abnormal findings, like there is a piles, or in some cases with a rectal fissure, right? Also in some cases you are able to find there is a fistula as well. So these are the typical finding you must look for in case of chronic constipating a patient, because in case of chronic constipation they are often associated with 1 2 3 4 5. Okay, so in case of chronic constipation, they are often associated with some complication, so you do need to take care of that. Okay. Also, like I have already mentioned that there is few alarm features, like the red flag signs. In that case you do need to go for the colonoscopic examination. Also there is a further tests. These are there for you to help you to determine what is the underlying disease, if the patient is pretty much refractory to the conservative management in that case. So they are the anorectal manometry, there is a colon transit studies are there. Also there is a difficography that is there for you. Okay. Now regarding the management principle, obviously there is few general measures are there. So we ask the patient to take the high fiber diet, like the bran, fruits and the vegetable nuts. And the fiber diet every day must contain around 20 to 30 grams per day. Okay. So in that case your adequate fluid intake is very much important, like 1.5 to 2 liter per day. But if you guys are practicing in some humid areas or the Indian subcontinent. In that case, your fluid intake is supposed to be much more than that, like around minimum 3 to 4 liters is supposed to be taken in a day. Always try to understand the regular exercise is pretty much important, and also the importance of the bowel training. So regarding the bowel training, few important aspects, like always ask the patient to have try to get a bowel movement done at the early in the morning, because at that time the bowel movement frequency is pretty much good. And also try to take advantage of the gastrocolic reflex just after taking meal, around 30 minutes after taking meal. So that are the thing you one must do. Okay. Now regarding the pharmacological management, okay, so there is a first line which is the bulk forming agent. So these are either soluble agent or the insoluble. So within the soluble agent there is a psyllium and there is a isobgol, and the insoluble one is the methyl cellulose, right? So one thing you need to understand regarding the bulk forming agent, they basically try to absorb water from the surrounding areas. So that will they basically form and bulk of stool, and that will eventually get passed through it, and it basically softens the stool as well. So this is the importance regarding the bulk forming agents. So regarding the bulk forming agents, they are pretty much well mm, tolerated in some patients, but the one thing that is there, like the gas bloating and excessive bloating and the gas production is one of the most common adverse effect that is there. Okay. Then comes your stool softener. So regarding the stool softener, like the emollient laxatives are there, like there is a, so they are usually well tolerated. They act by decreasing the surface tension. So as they act by decreasing the surface tension in patients, so it gives the advantage of absorption of the water into the stool bulk, right? Now, this emollient laxatives like the docusate, sodium, and the calciums are there. Their typical utilization and they typically used in case of painful defecation. These are the typical examples. Okay. Then comes your second line, which is the osmotic laxatives. So in the osmotic laxatives, there is a milk of magnesium, there is a polyethylene glycol, lactulose, and the sorbitol. Now, regarding the milk of magnesium, they are typically contraindicated in the patient of the congestive cardiac failure as well as in case of chronic renal disease. Okay, so this is the next thing, and obviously your osmotic laxatives, they are typically the hypertonic fluids that they are like hypertonic solution. So they basically drag water from the intestine, and that's how they basically soften the stool in that case. Also there is a stimulant laxative like the bisacodyl and the sena. They are typically used for the short term purpose, but one thing that always I would like to say is that they are usually contraindicated in case of elderly population. Obviously, apart from that, there is a secretagogues like the lubiprostone, linaclotide. So this lubiprostone and the linaclotide is basically used for the constipation predominant IBS. But also apart from that, there is a prucalopride, which is the 5-HT4 agonist, which are often used in case of refractory cases. Okay. Now, regarding the special situation, obviously, as I have already mentioned regarding the elderly population, but regarding the pregnancy, it's a safe option, includes the bulk and the osmotic agents you can easily use. Now, regarding the opioid induced constipation, always try to avoid fiber alone. Okay. So, in case of opioid induced, obviously you can use the pamodas like there is a naloxegol or there is a methyl naltrexone you can use in that case of opioid induced constipation, right? Now the non-pharmacological and the surgical option, like in some cases the patient is suffering from some pelvic floor dyssynergia, you can start the patient on the biofeedback therapy. Your surgical option is always there for the refractory cases, but before that you do need to evaluate the patient with such cases. your subtotal colectomy and the ileorectal anastomosis is basically there for you, especially for a short transit constipation without any outlet obstruction in that case. Okay, so this is your constipation in a nutshell, and especially we are discussing the acute and chronic constipation management in that case. Thank you. If there is any queries from you guys, do let me know. I'm happy to answer your queries.